lead, health equity lead for the Department of Medicine for One Brooklyn Health. So thank you to Dr. Hare for sharing slides, and we can go ahead and advance to the next slide. So I always like to start this conversation with local data because this is not a theoretical conversation or an academic one. This is a conversation around the reality that really affects our patients and our communities' lives every day. So let's start with a story, which is a true story. We'll name these patients Richard and Wesley. Richard identifies as white and lives in Manhattan. Wesley identifies as Black and lives in Brownsville. They live about 5 miles apart in the greatest city in the world, New York City. Next slide. In Wesley's community in Brownsville, there are 31% less students graduating high school on time compared to Richard's. In Wesley's community, 63% less adults aged 25 and older have graduated college compared to Richard. Next slide. Wesley lives in a neighborhood where the community is 3.25 times more likely to be unemployed. Wesley is 5 times more likely to be unemployed than individuals living on the Upper East Side. Next slide. Wesley's housing is 5 times more likely to have a housing violation than Richard's. If we compare Wesley to someone living in the financial district, Wesley would be 55 times more likely to live in a neighborhood with serious housing code violations. Next slide. In Wesley's neighborhood, 68% of total households have mobile broadband access. In Richard's neighborhood, 93%, almost 94% of households have mobile broadband access. Next slide. In Wesley's neighborhood, the preterm births are 2 times higher than in Richard's neighborhood. So for Brownsville, that's a 13.9% preterm birth rate compared to Soho, which is 7.7%. Next slide. In Richard's neighborhood, 70.9% of total registered voters voted in 2020. So these are already taken into account folks that are registered, who amongst them chose to vote. In Wesley's neighborhood, just over half, only 52.5% of total registered voters voted in 2020. Next slide. And these inequities that we see in our communities go all the way through death and premature death. In Wesley's neighborhood, the premature mortality rate is 9 times higher than in Richard's neighborhood. So in Brownsville, the premature mortality rate is 584 per 100,000 New York City residents. In Greenwich Village, Soho, it's 64. So what are we talking about here? We're looking at the geography, and we're looking at the intersection of the geography with social determinants of health. So to start out with, what is our definition of social determinants of health? These are the conditions that are all around us in our day-to-day life, where we work, where we live, where we play, where we learn, where we worship. And we know that these have an enormous impact on our overall health. So there are a variety of frameworks that attribute different percentages to overall health, but the overall proportions are usually quite similar. So you can see here, social and economic factors are 40% of what determines health and include a wide range of issues: education, housing, income, incarceration rates, graduation rates, some of these which we just included. 10% of health outcomes is driven by physical environment, such as buildings, transportation, natural environment, access to sidewalks. About 50% is estimated to trace back to your zip code. So that's what we were looking at earlier, neighborhoods of New York City. Some people say that your zip code is as important, if not more important, than your genetic code. And think about all of that time we spent in medical school, for those that are clinicians or in your training generally, obsessing about, is the BRCA there, is it not there, right? But are we talking about the zip codes and those structural defining features for social determinants that have such an enormous impact on health outcomes? An additional 30% of outcome is driven by health behavior, which is complex. Health behavior often is driven by the context in which we find ourselves. And around 20% of health outcomes is driven by access to care and quality of care. People are often surprised that healthcare actually plays a relatively small role in what ends up determining our overall health. The social and economic drivers in the purple and the green are much more influential. But the good news is that although the word determinant seems to imply that these factors determine our health, that does not have to be the case. And in fact, there's been a movement to call these social influencers of health. Each of these social determinants or influencers can be influenced and changed through the work that we're going to talk about today. Interprofessional teams with support from community-based organizations, advocacy, policy change, community engagement, and other means to better support whole health. Next slide. We can't talk about social determinants of health without talking about the larger ecosystem of our society that we find ourselves in. So this health equity framework, which is based off of work from Cambridge Health Alliance and Dr. Camila Mateo, really demonstrates the concept of intersectionality. So that means as we think about these social determinants of health, social capital, education, transportation, et cetera, they do not exist in a void. They exist in the structures our society has created that impact each of those social determinants of health. So those structures are often various forms of oppression, such as racism, that directly impacts health outcomes and also interacts with social determinants of health. So for example, redlining in history in America, where we know redlining impacted access to housing, and we talk about housing being such a great driver for social determinants of health. So this specific framework really highlights a number of these interactions, including homophobia, transphobia, xenophobia, ableism, sexism, amongst others, that we have to keep in mind as we think about each of these social determinants of health and how we're addressing them in our clinical settings. Next slide. So as we think about a model for reducing health inequities and addressing social determinants, we must think about this entire landscape. So that includes social inequities, institutional inequities, living conditions, risk behaviors, disease and injury, and mortality. And then the pieces that with the antidotes that we can really bring to this work, which includes what we'll discuss today around interdisciplinary teams for addressing social determinants. It's really upheld by a policy landscape, which allows us to also think about strategic partnerships for advocacy, community capacity building, community organizing, and civic engagement, as well as the pieces we'll talk about today, case management, healthcare, and individual health education. We are very fortunate to live in a state where we are expecting the next Medicaid reimbursement model, called the 1115 waiver, to really support the financing mechanisms that will allow us to be able to invest more intentionally in what it looks like to assess and address social determinants of health. So we will be at the forefront nationally as we think about this, and is a great opening to how we think about our teamwork together across our professions to really meet our patients and our community's needs and realistically where they are. So with that, I will pass it off to our next panelists.
Thank you, Sophia. Before we move into our next panel's introductions, I just want to acknowledge Dr. Jessica Kahn, who is here with us today. Also, she is one of the other PIs on our HRSA grants, and she's here today. So I just wanted to make sure to acknowledge her. And Dr. Evan Sunreich is not here today, but he also leads these grants with us. Okay, so I am going to turn it over to you all. Sharon, would you like to get us started?
Sure. Hi, everybody. Welcome. My name is Sharon Beaumont. I'm a speech language pathologist by profession for about 20 plus years. And I'm on faculty in the graduate program at Brooklyn College. My clinical background is medically based, working across the age continuum. And I've been fortunate enough to work throughout the boroughs with, a varied population in terms of culture, language, and diversity. And I'm happy to be here today.
Thank you. Would you like to respond to some of the comments that we have for the panelists? We'll let each of you respond to those before we move on to the case after each of you discusses.
Sure. So you want me to chat a little bit?
Yeah, chat a little bit.
Sure.
We'll let each of you introduce and
Sure.
chat a little bit, and then we'll move into the case.
Absolutely. So I think, one of the things I had been thinking about in kind of preparing for us to meet together today was how, as speech language pathologists, as allied health professions, how our biases come into the care of our patients. Historically, what you may not know, or maybe you're aware that speech language pathologists suffer in terms of diversity. So that even in the metro area, there's a significant lack of diversity when we are treating and assessing a population that's extremely diverse. So I think as much as education as we're doing in the classroom, there's still a disconnect, and we as clinicians bring our biases into the treatment room in terms of what we anticipate for a patient or a client, what we expect the patient or client to be able to do, and really what we expect those goals to be. As a profession, we're goal driven, right? So not unlike the case we'll talk about today, we see patients that have a primary medical diagnosis and then have resulting residual speech, language, cognitive swallowing deficits. And I think while the field is shifting, while we're opening up and being a little bit more mindful, we do lose some impact when we don't consider where the patient goals might be, what the purpose of therapy is, what the socioeconomic status is of the patient, what the patient supports are. I think becoming better at acknowledging and understanding the stressors for our patients is really important. We like to come in and be problem solvers and set up some goals, as I said, and move forward. But that doesn't work if you don't consider and understand what the patient's stressors are. What are the supports? What does life look like on a daily basis for the patient? It's really easy to set up some goals and say, if you do this, things will get better, right? If you follow my guidelines, speech will improve. If you follow these guidelines, aspiration won't be that much of a risk. But stepping back and understanding what's important to the patient and what access to care the patient has to drive what we're doing as clinicians. So I think that's certainly something that comes to mind. I also think building trust and rapport with our patients. Again, we're not a diverse profession. So lots of us come having done, I can do all the reading I want about different cultures and religions and populations, but I really need to engage my patient to determine best what does that patient need based on all the social determinants of health. So how can I maximize care for the patient and not just put a stamp of treatment on it? One of the other things I wanted to just kind of quickly talk about is what our expectations are versus what the patient's expectations are based on resulting impairments. So while I might find it important to work on a patient's cognitive abilities and restore their reading comprehension skills or their higher level cognitive function, what might be most important for that patient is to be able to get back to their role within the family, right? From a socioeconomic standpoint. While I might think it's important that a patient has a specific diet of a specific consistency or the use of commercial thickeners that are fairly costly, what's important to the patient is getting back to work so they can put food on the table, right? And how do I reach out to my peers and my colleagues to make sure that I'm meeting therapeutic goals while also meeting the patient goals, because I think that's how we otherwise lose patients. And I think that is a work in progress. But being mindful of that and understanding that it's a partnership and reaching out to my colleagues, I think our colleagues has been helpful in managing that. I'm not sure, I could go on and on and on. I'm not sure how much further I should go. Should I keep going?
You have 1 more minute if you'd like to, otherwise we can move on.
Sure, no, I have more to say. I do think one other consideration is, that when we're making specific to swallowing disorders, which is a big part of what we're doing in the medical setting, being mindful not only of background and access to care and financials, but also culture and what food items are expected and what growth and development looks like in cultures when we're talking about the pediatric population and also the adult population. So I do think to get buy-in and to build that partnership, sometimes we have to shift what our goals might be to best serve the patient. So again, really being mindful of the process and how it looks to the patient.
Thank you, Sharon. That's fabulous. Mitchell, you're next on my screen.
Okay. Hi, everybody. I'm Mitchell Hare, Dr. Hare. I'm one of the third-year residents, chief residents at Brookdale Hospital, part of One Brooklyn Health. So great to be here. So I just want to kind of reflect a little bit on the past 3 years, about to graduate soon. So the past 3 years of my residency training and the social determinants of health and how I've interfaced with these. So during the past 3 years, not necessarily during the peak of the COVID when I started, but every subsequent wave I experienced afterwards, it became more and more painfully apparent that the people in the setting of the lowest socioeconomic status and with limited access to care with reimbursement rates from insurance that can't even close the gap between revenue and operating costs, these are the people that suffer the worst. And how do we know that? As the need increased during the COVID pandemics, the suffering also increased. So this goes against all expectations for us as healthcare providers and what we want, right? We don't want to see our patients suffer. We want to actually help them. But as Sophia outlined, the social determinants of health and the social influencers of health are a larger part of that rather than the healthcare system. So really the question becomes, why did this occur? How did we let this happen? And you could ask, what did the healthcare system, did it fail to respond appropriately? And you could probably argue that we know what is happening and everything that's going on, it's fine. But the other thing, for the purposes of this discussion, obviously, I think it's more along the lines of the social determinants of health that affected people the most. But this is really, why, we're just not asking our people, right? We don't really know that for sure because we're not asking. And this isn't a problem unique to us. There's more and more of a push towards entertaining these social determinants of health and addressing them, but we're not asking. That's not the current practice. So where do we begin? We must understand the community that we're serving, right? And we have tools like we can use technology to augment, right? To track these metrics, to ask the questions, right? And then no doubt, the more and more time that we spend devoting to this relationship, the trust will also increase, right? The trust, it's known that the trust has declined after the COVID pandemic. The trust for the healthcare system has declined. So we have to start developing those relationships with our patients. But then the next question becomes, so what are the limitations? Why are we not asking these questions? So as a resident, I don't know, that's what it comes down to. I don't know. So I don't know what to do if I ask about somebody about their food insecurity, which affects 13% of US households, by the way. What am I going to do if they say yes, right? What do I tell somebody that to the person that comes into the clinic that I'm treating for a sexually transmitted infection, and the reason that she got that sexually transmitted infection because her occupation requires her to do things that she would rather not do, but it's either that or no food on the table, right? So we have to understand how we can put these patients into the right networks of healthcare professionals to get what they need. But imagine, if you will, you are a patient whose trust has been tried by a healthcare system who hasn't been there for you. Training programs haven't largely been structured in a way that allows a longitudinal, lasting, continuous relationship with their patient. And as training programs and healthcare professionals, we must prioritize continuous relationship with our community, and not just with the doctor, just everybody in this room right now that's a healthcare professional. We all must be in this together. And we all must have a panel of patients that we communicate with so we can optimize the care. So this has been done. There's a few organizations, the Greater New York Hospital Association, 2018, they partnered with predominantly a primary care residency to work on this, to develop stronger relationships with community-based organizations, which should be our goal. And then other residency programs, it's one in St. Louis back in 2011, a family medicine residency program. They started to, and also University of Cincinnati, and more recently Brookdale with something called Long Block, we started to change the way in which programs were designed to develop these longitudinal relationships, to develop trust with our patients that we have, and really start to dig in deep to these social determinants of health, these social influencers of health, so we can begin to address these things. But really it starts with developing these relationships with community-based organizations so we can get people networked and linked into the care that they need.
Thank you. That was great. Okay, Natasha.
Hi, everybody. Thanks for joining and thanks for having me here. I'm representing the field of nutrition, which is an exciting place to be at this time. I think a lot of people are thinking about their own personal health and the environments that we're in and our food choices. I've been actually working with One Brooklyn and Brookdale for the last few years, but in the communities of East New York and Brownsville for about 10 years now. And that's been work including, food insecurity and working at food insecurity programs, and then now nutrition counseling one-on-one. I'm a certified diabetes educator and adult weight management specialist. So one would think, people coming into my clinical room are just there to talk about portion sizes on carbohydrates and things like that. But, sort of speaking to what's already come up so far from the panelists, trust is a really big factor here. We have patients who are resistant to taking medications, feeling alienated in the medical system with their experiences, and having the, I think vantage point of being a nutritionist, I get so much more time with my clients to really sit and talk about what's going on and build that rapport and trust that everyone's mentioned so far. So when I think about, best practices in communicating with patients of diverse backgrounds, I think it really is being patient-centered in that room and in our approach to really listen to our patients and let them set the standards and goals for their treatment plan. So for example, if I would love to help someone get their blood sugar down by talking about, when they take their medications, it might be a concern of, do they have a safe place to store their medications? Do they have the ability to see or read the labels on these products? Is literacy a concern? Are they able to pay for these products, these follow-ups, these specialist appointments? So communicating with respect does really require some deep listening to hear when our patients are starting to bring up these sort of social determinants of health in session. I, like many other providers, might want to just rush through and get to the next topic and make sure we're hitting all of our clinical goals, but our patients are usually starting to hint to us what their priorities are if we can take some time around that. And some of that communication that's happening in the exam room, it can become more intimate when we know we have a structure around us that's supporting screening for social determinants of health. And so I think that can be a big missing piece in a lot of different medical settings, is how are we creating this culture of care that's going to allow the patient to feel like, yes, we are here to address these and we're here to listen to you in session. So I just wanted to pull up on the screen. Hopefully this will work, a little bit of a screen share. Let's see here. Okay. Can you all see my screen? Hopefully
Yes.
so. Okay, great. So I just wanted to share with you some of the ways that we can sort of standardize looking at social determinants of health and creating a culture of care. Something that's really meaningful, that's going to tackle these needs. A lot of times we might come in for one with some of our own ideas of what the most important social determinants of health are affecting our patients or our communities. So screening is going to give us a way to get that data, and we can really build that in a medical setting by using codes. So codes aren't that fun or sexy if you think about it, but in terms of being able to do work and make meaningful change, they're actually really exciting. So in the medical setting, we're using classification codes for like diagnoses, symptoms, procedures that we're doing. But recently, Centers for Medicaid have really pushed these new codes called Z codes, which are looking at social determinants of health. And you can see here some of the ways those are broken down. And then under each of these Z and then number categories, you would see more definitions of social determinants of health. So coding is actually a really cool thing we can do in our medical visits to start to create a robust pool of data to better understand our clients. So this is something that clinicians can be doing, using these codes in session to start to really be reflecting on their patients' needs. And, as we can step back with that data, this can be a really promising approach for funding, for making community partnerships. But again, we're really building into a system, a sort of culture of care that's looking at social determinants of health. And these codes could be pulled in during a clinical session, but we're thinking also that this can direct us towards the best tools and resources to screen our patients. So for me to do the best work I can one-on-one with my clients, I like to have that sort of foundation, knowing that other care points, other touch points at the visit, patients are getting asked screening questions, and we're figuring out from them along the way before they even make it to me, what are some of their main concerns. And having a sort of standardized screening approach is a great way to then have a more soft approach in the clinical room, knowing that these things are going to be addressed with the patient. So screening is, I think, a big part of the piece, screening and then referral, right? So as a nutritionist, I'd love to just focus again on some of the food choices people are making, but whether it's food insecurity, financial insecurities, or others, we know that we're going to probably need to have community partners that we work with. We probably all have experiences where we see a big gap in the place that we're working or in the classroom, and we see there's that need, but that doesn't always mean we can jump in and fill that need ourselves. So building partnerships is a really big piece of this puzzle. And then also training our team members, whether it's doctors or medical assistants, social workers, the whole group should understand not only how to screen, but how to refer patients out. So I just want to share quickly some resources that I find are really useful in the communities that I serve. I tried to break them up by category. Definitely might want to take a screenshot of this here. But the first listing I have here, heightsite.org, is a really excellent database for programs across New York City. And you can just type in a zip code, a care need, and find something that's going to work for your patient in the community that they live in, which is amazing. So a lot of times in session, I'm directing patients to the Plentiful phone app, which is a way to find food pantries and soup kitchens in the community. Signing patients up for God Love We Deliver or other meal delivery programs, especially for like our homebound seniors. I recently had a patient who came in with uncontrolled diabetes, and she was clearly displaying signs of malnutrition, feeling super disconnected and isolated and alone, living by herself. And we found a senior center right around the corner from her house where they're providing her meals, testing her blood pressure on a regular basis. She's getting fitness programs. She's making friends in a neighborhood she'd never lived in before. And all of this is an excellent foundation for me to then come in as a dietitian and talk about portion sizes and sugary drinks and all of that fun stuff. So I just wanted to share, if anyone has questions later, I can definitely talk about some of the resources that I pulled up on the screen here. I'll stop sharing my screen. But yeah, that's it for me for now. Thank you.
Thank you so much, Natasha. That was fabulous. And now we'd like to hear from Dr. Gwen Lancaster.
Hi, good afternoon. I'm Dr. Lancaster from the nursing department at Lehman College. I've been a nurse for, I can't even recognize how long it's been. It's been that long. I am currently, I worked in med-surg, critical care, ICU, and now I'm teaching. And one consistent thing that I'm hearing, and I'm hearing it from the other panelists as well, is distrust, and building that trust. That has been a major issue when it comes to healthcare, no matter what part of the field that you work in. We're talking about the fact that people don't feel like they're being heard. So you have to take that opportunity to actively listen to them. It really doesn't take that much time to be present in the moment. If you're present in that moment, they will share a lot more about their situations than you really sometimes want to hear. But you need to know that and build that relationship. We have to take a stance where we're not making assumptions about the people that we come in contact with, which is another issue that I find. I also find it on the other side of being a patient in certain areas. I recently was in the hospital myself and had to be on the other side and listening to what the social workers had to say, the physicians had to say, and then there was my point of view. And my point of view might have been a little bit different as the patient, as well as being a registered nurse. But what we have to remember, we're always taught patient-centered, person-centered, and putting that person in the middle. But if we're not willing to listen, actively listen to what they're trying to say to us or trying to get across, we will not make those connections, and that distrust will only grow. We talk about ethical considerations when we think about the clients that we engage with. They have the right to determine their own health. It may be different from what we think it should be, like someone else was just mentioning that recently. Well, if you do this, then this will happen. Yeah, but if I'm on the other side of that, I may be, it doesn't make sense to me. It's not making sense in the way that I live my life, in my culture, my environment. All of those things come into play. So I need to talk to that person and engage them in a conversation that I can find out what is it they need from their perspective. For example, someone was mentioning diabetes and insulin. In some cultures, my culture in particular, it's sugar, okay? So they look at it as having sugar, but it's more to it. Why can't I have my milk? Well, they need the milk, but we need to explain to them why and how these things can fit into the way they live their lives. What are you willing to do? What kinds of things are you willing to change? We have to engage the conversations in order to help them to reach the health that they see. For example, I like to tell my students, there are some people, when they talk about being healthy, they can run a marathon. For me, being healthy is being able to walk to the corner without dying of shortness of breath. It's all in the eyes of the beholder, so to speak. So as healthcare providers, we really need to maintain that perspective from the client and let the client dictate how we will work with them. They are an integral part of the team. Often we tend to, as healthcare providers, say, we got the information, we went to school, and this is what should be done. And then we don't understand why there's a barrier. People put their backs up and say, well, who are you? How are you telling me what I need to do? We have to really, for me, the biggest part is creating that partnership. Someone was saying that before, that partnership with our clients that we are working with, so that we can actually work with them to get them to the best place where they see that they are healthy, how they perceive their own health. Another thing that I was thinking of as I was looking at some of the questions that were posed is the language that we use. Different perspectives have different disciplines have different languages, and just going over some of the things that I was reading, I was like, if I can't read it and I don't know what's going on, I can only imagine what the patients may be thinking, what the clients may be thinking. So looking at how we term things, how we formulate our relationships is really important. For me, the relationship is the most important part when it comes to helping people with disparities, healthcare disparities. Community resources, there was another thing that I wanted to bring up, but no, actually I did it. all in a nutshell. For me, the main thing is making that partnership with the client. And to do that, we have to engage them in conversation, true conversation, a two-way conversation, not from the top down, I'm telling them what to do, but engage and embrace them in the conversation. Thank you.
Thank you, Gwen. That was great. So I want to draw everyone's attention to what I put in the chat. I put in the chat a case example that our panelists are going to discuss in the next part of our workshop. So each of the panelists that you've heard from, including Sophia, will have an opportunity to discuss with you their reactions and their potential plans of action for this case example. And I also want to encourage everyone to put questions or comments in the chat. And once the panelists have started to discuss and everyone's had a chance to, each of the panelists has had a chance to respond, we will respond to some questions and do a Q&A. Okay. So I'm going to let you all kind of decide how you want to order yourselves. We can go back to the same order that we had before, or you can organically discuss with each other.
I think we should organically discuss with one another.
Okay, go for it. I think so too.
Yeah, so the first thing I would lift up is, as some of our other panelists have mentioned, really making sure that we are being patient-centered and whole patient-centered and listening, right? Do we get a clear idea from the case? What are the patient's priorities?
Mm-hmm.
What is important to the patient? What does success look like for the patient from this long, complicated hospitalization? And making sure that we're starting from that point of identifying, this is their life. And what is it, the way that we can best serve the patient's life and those priorities. And the second piece I would lift up as well is making sure that whatever plan we come up with, it is truly authentically accessible for our patients. And when I say accessible, that means the language that we're using, as was brought up earlier. And we don't even realize some of the challenges our patients had. In the last week, I had one patient who was born in this country from a always English-speaking family, that when we were making a passcode for logging into MyChart, she wasn't familiar with an exclamation point and where she would find an exclamation point on her phone or on the computer, right? We make so many assumptions. I had another patient who finally on the 4th visit with me felt comfortable enough telling me that she actually can't read at all. And despite her diagnoses of HIV that she's had for 30 years, she's never been able to read a single thing of all of these materials and papers, right? The system has been giving her, oh, you need food resources. Here's this pack of paper with all of these phone numbers, right? But she can't access any of that information because we're not actually first sitting down and listening and meeting our patients where they are and doing true accompaniment, which means that our patients are deciding when they're letting us in, and our patients are deciding how long they are letting us accompany them in this journey and this process of meeting their social needs, as opposed to, unfortunately, as we often do, just throwing a lot of papers at the patient and saying, hey, here are all these resources. That is not the definition of access.
Sophia,
so I'll pause there and pass it to my co-panelists.
You just mentioned something that's been a bane in my existence for a while when we talk about discharge planning many times and discharge teaching many times.
We can't hear you.
Oh, I'm sorry. Yeah, my microphone is on.
We got you now.
Oh, okay. We talk about discharge planning from a nursing perspective. It's supposed to start from the very moment that we meet our client. However, what it has boiled down to in practice is doing exactly what you're saying, handing them a bunch of papers at the end of their hospital stay and say, you go here, you go here, you go here, and you go here, without really giving them time to ask questions or time to say, they'll nod and you'll assume that they understand what you're saying without engaging them in the conversation to understand whether they actually do understand what's going on. They may not, like you said, they may not even have a phone. We assume that they have a phone. They may not. For quite a while, I didn't have one until my grandma made me get one, which is a story for another day. But we do tend to assume things about our patients and our clients.
I'll just kind of jump on here. When I look at this case, I think, oh, this patient is ripe for speech language pathology intervention, both on the cog linguistic side and on the dysphagia side. But But again, circling back to what's important to the family, given the fact that the patient's husband recently lost their source of income. So how important is, being able to do what the patient did before relative to, higher level communication, not just meeting your basic needs. It is, where does that stand for the patient and for her caregivers? What's important? Does she need to be able to get through the basics of the day, regardless of what I think the patient is capable of? Where does that stand? Where does that land for the patient? I also think in a case like this, when there's so many providers, sometimes it's overload, right? So my goals are more important than the OT's goals. Nursing goals are more important than my goals. So where does it fit, and how can I kind of weave together with my teammates, the team members who are equally as busy, but how do we weave together to make sure you're doing a little bit of my stuff and there's clear overlap, because the ultimate goal is let's improve, function for this patient. So, I think this case really allows you to look at where could there be overlap and potential for true interprofessional practice.
I think that's a great point. I think it's very important that we all communicate effectively as one care team for the patient, right? So I think that's part of the problem too. We send patients to different professionals, and then they come back to the provider or come back to you as a speech and language pathologist, and it seems like nobody's communicating with one another, right? So that has an impact on the trust as well. And it also creates somewhat of an illness script, like, am I sicker than I really am, right? You go to a primary care provider, and then the next thing you know, you've been referred out to multiple providers. It's like, wow, my diabetes must be so bad that my general PCP can't even treat it, right? So it creates this illness script out of proportion of the actual patient's health status, and this also causes an impact on their psychological health as well, and their emotional well-being. So I think just looking at this case really highlighted the need for really effective communication as a care team.
Thank you. Do any of you have any ideas about how we can better communicate among the interdisciplinary team members in an instance like this?
Again, I think it's a conversation among the healthcare providers as well. Like we were saying before, we do write our notes, and these notes are written in different types of languages. So I may read your note and not understand what it was that you felt or saw with this particular client. So it behooves me to reach out and ask questions. If we're in the same room, that helps, but that's not always the case. If I'm reading some notes, I should be open enough to reach out and ask questions. I read this about it, but I'm not sure what your perspective is. Can you give me a little bit more insight as to what you were thinking? Because we each have different perspectives, and somebody also said that some of our roles overlap as well, but knowing what was done is part of what we need to be able to continue to help that person grow and get to where they need to be.
And certainly screening options, making sure that we are consistent in the ways that we are screening can help with some of that commonality of language. The reason to use standardized protocols and standardized questions in a place in the chart that is accessible to the entire care team. How many times have we all found like that really critical social work or case management note, but it's somewhere buried amongst 400 million other notes from the ICU where God knows what was happening. And none of us actually had ready or easy or awareness of the fact that actually one of our care team members did a phenomenal job assessing this patient. And the rest of us totally missed the boat, and we didn't have an opportunity to come together and have that conversation. And when we are able to screen with a universal tool that is in one place that everyone knows where to go to, we also start to realize the way that our work interconnects. When we've studied this before in other settings, it's not obvious to some folks, like for our social workers at one of the other institutions I worked at, it wasn't immediately obvious, oh, the pharmacist needs to know this information, because the way we choose to prescribe for this patient is going to hugely change based on which insurer they have, their ability to pay, their ability to actually adhere to medication. It also hugely changes the words we're using in a chart, right? How many times have we seen non-compliant? How many times have we blamed the patient for their AMA status, leaving the hospital against medical advice? But meanwhile, who else is going to care for their kid at home, right? It's not, if you're put into the situation of taking care of your child or staying in the hospital, sometimes there's no alternative. And we do so much patient blaming without really thinking about what is driving the needs of our patients. So really it's about us as a system as we think about social determinants and that interprofessional conversation, moving from understanding that our patients' decisions are sometimes trauma-driven and our response must be trauma-informed. What does it mean for us to understand the trauma that our patients are carrying from their community, from their own lived experience, and then adapt our interventions to something that's actually realistic for our patients? The lived experience of our patients is always going to be that strongest determinant. If we are not listening to that lived experience, it doesn't matter how evidence-based we think our intervention is, because it's not going to be evidence-based for the life of that individual.
Yeah, I noticed someone dropped in the chat a comment about effective communication, being part of that being we make sure the client understands us. But I like to always take time to repeat back what I've heard as the client's priorities in terms of their own care. I know what I need to get done, and I'd love for them to follow my guidance, but I think that if I can really repeat back and help them feel heard, it's going to help us all be on the same page and make it really clear when we're forming care plans with the team, how we're going to prioritize things.
Thank you. Do any of you have any comments about language that we might use with our clients and patients to help them understand that we know about their social determinants of health, the issues that are there? I think talking about it as a professional is different than actually talking about it with the client. So how do we talk about it with them versus how do we talk about it ourselves as professionals?
As Sophia was saying earlier, meeting the person where they are and using the words that they can understand. And you can also ask them, ask them how they, for example, when we talk about language, we're assuming that the person understands English. They may not, or they may understand some, but that may not be their primary language. And sometimes their culture may also play a part in it. So meeting them where they are and then working from that perspective will help us do the best that we can. We also have to recognize that sometimes we may want to do so much with them, but they may say no. They have the right to say, no, I'm not willing to do that. I'm living. This is what I do. This is how I see it. Quality of life is different for different people. What I see as my quality of life is different from someone. And I can give you an example from when I was practicing. I used to think that quality of life meant I could get up, go out and do, and I have to. But I had this one particular patient who had diabetes. She had amputations, more and more, all the way up to both hips, amputation. She had bed sores on her sacrum, both scapula and her sacrum, everywhere. She had bed sores everywhere. She was on a specialized bed, and I had the duty of going in to change those dressings. And every time I would go in, it would hurt me. I would say, why are we putting this person through all of this pain? Why are we doing this? But then I learned from the patient, who would look up at me and say, darling, I'm so glad to see you. And I'm saying, I'm so sorry I got to do these things to you. And she would say, for me, I'm so happy that I could open my eyes and see that smile. She would greet me with a smile every day. And here I am thinking that I'm creating her pain, but she's saying, I'm here and I can see. So doing it from the patient's perspective, we have to accept where they are. Not everybody that we come in contact with is going to want to change to the degree that we think they should. So how, as professionals, are we willing to accept where they are? Are we willing to meet them, really truly meet them where they are, so that we can help them to be the best that they see themselves as, and maybe guide them a little bit more as we get closer to them? Just food for thought, because this conversation for me is really engaging, and it's really, we really need to have it, I think.
You know, I think it's important to realize that a patient's only going to let you know what they want you to know at the time. And I know that's also a matter of trust. But it brings to mind a patient who came to us years ago. She was HIV positive for many years. She'd been in care for quite a long time, in and out of care, and she was pregnant. And the OBGYN attending was the first person who ever noticed or figured out that she was hard of hearing. And this was before COVID, so people weren't wearing masks. So she was able to read people's lips. So she got by. And nobody ever realized that she needed hearing aids, and she refused to tell anybody. And this particular doctor, who she developed a trusting relationship with, was able to get her to agree to a referral for hearing, a hearing test, and eventually hearing aids. But it was years that she was, in care, and nobody ever picked up on it. So, obviously we had to deal, she wasn't getting any of the messages that people were giving her. I mean, some of them, but not all, obviously. Yeah, thanks.
Thank you. We'd like to open the discussion to the audience for some discussion and question and answer. So you can feel free to raise your Zoom hand or put a question in the chat. And we'd love to hear from you. You can react to the case or ask a question of the panelists. Dr. Lundy.
Hi, I'm from the nursing department as well as assistant professor from nursing. And anybody who's been in the field really has a different perspective. So we've all, especially Dr. Lancaster, I know she's worked in the field, and so have many of you. But what I find to be sometimes problematic with communication is that when a patient says something, we are so anxious to teach and to get them to do what the professional says. And we're not really, as Dr. Lancaster says, we're not really hearing what they're saying. And until they build that trust, I don't want my patient just to say, I'm following this diet when I know they're not. The A1C tells me that they're not. I'd rather you be honest with me so I can give you some tips on how you may be able to follow the diet a little better. Maybe they're not going to give up everything, but maybe they might give up that cupcake in the night, or they might just eat one piece of bread instead of two. So I'm willing to negotiate with them and to help them be honest with me, because I'd rather them be honest than to say, yes, I'm doing it. I know that they're not doing it. They know they're not doing it. So there's not really this genuine connection. But once they have that trust and a genuine connection, they'll tell me, yeah, I ate pasteles all weekend and so. Okay, well, you're going to do that for Mother's Day or for the holiday. Now, how can we get you back on track so that you're not overdoing it? So you have to kind of accept them for what they're saying and try to work with them, negotiate whatever you can to get them to have better health.
Is somebody in the chat is mentioning motivational interviewing techniques? Do you want to unmute yourself and talk a little more about that?
Sure, I'm happy to. I'm sure there are others on the call who also know, but motivational interviewing techniques is really a sort of a mode of building trust and habit changing in the helping profession, particularly social workers, psychologists, and psychiatrists. It's worked really effectively with people who have been substance abusing and are interested in changing habits or smoking cessation. And really the idea is being able to work with the patient around the impact of habit, changing the habit, what benefits them by changing the habit, what benefits them by not changing the habit. And so through techniques, you sort of develop, I think, the idea intrinsic motivation to change rather than sort of a meaning doctor to patient motivation. It sort of comes from within the patient themselves. So I always thought it was really helpful. And I actually work with child adolescents. I'm a psychotherapist, and it works really effectively even with people who are not with addictions or compulsions, and works with any age group. And for those who might know more about it, please fill in the blanks and anything I didn't give context on.
Thank you. It's really helpful. I think the language that Dr. Lundy and that Dr. Lancaster used together are important in terms of having empathy for people when we speak, and understanding and helping them to be motivated to move forward. And I think the idea of motivational interviewing and helping people to kind of see the other side while having empathy and while trying to help them understand like the reason for the change is really good. I think it's really nice to have some language and some foundation to do some of this. It's hard to say we should address the social determinants of health without having anything concrete to use. And these are some good concrete suggestions. I have a question. As a former medical assistant, I feel that bedside manner is really important. How do you feel it can be bettered? As well as putting a time limitation on bedside communication because of patient caseloads.
That's a really good question, because in many of the hospitals now, some of the nursing administrators are saying that the nurses should spend X amount of time talking with the patient, or you can't really dictate how much time it's going to take to speak with someone. But if you're genuinely and being authentic with your patients, you can actually create a connection a lot faster than you believe that you can. One of the things that she was mentioning about what's important with bedside communication and caseloads is just that emotional, that initial contact. Let me give you an example. When I was in the hospital in the middle of COVID, at the peak of COVID, and everybody was covered from head to toe. You couldn't see anything from anybody except for their eyes. I'm in the bed, scared to death that I'm going to die. This young nurse comes into the room. Miss Lancaster, I'm going to be your nurse today. She stood at the bedside, not looking like she was going to run out any second, but actually stood there and engaged with me. And it only took her a minute to connect with me. And it helped to decrease my anxiety immediately. I remember that. I can't remember her name, but I can see her face as clear as day. So I truly believe it only takes authenticity, actually being present in that moment to start that connection with your clients.
And that could be as simple as just sitting down in a chair right next to the patient.
Mm-hmm.
Makes it much better.
Mm-hmm. That's true. Yep.
Thank you for answering my question. Makes me really hopeful in this context is knowing that part of what is driving this to the point in the chat is the structures which we are a part of and how we are defining how do we get paid, how do we get reimbursed. In a system that is fee for service, sometimes we get stuck in that. Oh, how many minutes am I spending in this visit? In a system that is moving towards value-based payment, which is our expectation with the 1115 waiver, and we know will be happening, all of a sudden the payment changes to, did we actually, primary care, close that care gap? Did we actually get the colonoscopy, and did we get there? And the conversation changes around meeting the social determinant needs to make it realistic for that patient to even be able to be adherent with that colonoscopy. The other piece is, again, when I opened, I really brought up socio-political determinants of health, because we also know that's what they are. Making sure that we are both aware of the history, the context of what we are working in, as well as the changing landscape. So COVID-19 vaccination was an excellent example of this, right? When vaccination came out, initially, there was this whole discussion, particularly in health equity communities, around, oh, well, a lot of our American Black population is bringing up Tuskegee and they don't want to get vaccinated. And that's why people don't want to get vaccinated, right? You got to know that history. You have to know what's relevant and why folks might get scared. But when we actually did the work nationally to figure out why folks weren't getting vaccinated, much of it had to do with access. If I do not have vaccination available in my community, of course I'm not going to get vaccinated. Right? So we had this script in our mind of biases that actually in our mind, those that were educated, that said, oh, people who are Black don't want to get vaccinated because of Tuskegee, but that wasn't even true. Right? It was a structural part of the way that we were delivering COVID vaccination access to information. Was there an element of the prior? Sure. Was it the vast, overwhelming reason why folks were not getting vaccinated? No, it wasn't. So it's about being aware of that socio-political landscape and listening, as we've all said so many times, to understand what are the structural factors that are defining the outcomes that we are seeing, and what are the structures that need to change for us to be able to change the outcomes that we're hoping to.
You mentioned something important when you talked about biases. A lot of us, we like to believe that, oh, I'm not biased, I don't have any biases, but when in actuality, we all have something. And the first step in being able to reach out to someone else is to be able to do some look at yourself, see what it is that you're feeling and you're doing, get in touch with that so that you can open up to other people. Too often, for example, you see the person on the corner and you assume because their pants are down that they're a gang member or something to that effect. Does that come into your mind? If it does, take a deep breath. I really did have that thought at one time. But once you start recognizing those things, then you can start making changes and opening yourself up to what the healthcare, the people that you're working with actually need. If that's what we're really focusing on and that's what we really intend to do, we have to examine ourselves first and understand, yes, we will have biases, but recognizing that and being able to work on that to open up, to be, to hear, to actually hear, truly hear. We've said it a lot, just like so many of us was talking about actively listening, but to be able to do that, we have to know who we are and be honest about ourselves.
Right, and having that humility to allow ourselves to be corrected. I worked nationally on a campaign for 3 years around getting rid of race-based renal function measurements. And it wasn't until a year and a half into that, I was using the term race correction variable. And one of my younger colleagues working with me said, when you say that term race correction, that's kind of implying like there's a correct and incorrect. Maybe that's not the best term to be using, right? But we are so immersed in some of this language that we're used to using that I had never thought of that before, right? And I needed to be called in by my colleague to say, hey, let's think about a different way that we're going to talk about that. And that made me better, that made our work better. So really being open in our interdisciplinary teamwork, it doesn't matter that I'm the attending physician, right? Anyone on our care team and in that interdisciplinary way should be able to call me in and say, hey, Dr. K, maybe that wasn't the best choice or the best words. Can we try something different?
I think that leads to just the reminder of reflective practice. So not only stepping back and looking at your actions and what do those actions mean, whether are they related to your biases, your past experiences, your education, that constant ability to look in the mirror and continually shift your clinical practice, I think is really, really important for all of us.
Yeah, I also think about the bias that our patients are experiencing from us and the assumptions that they bring into the exam room about what we're going to do for them or with them or without listening to them. And I think part of this self-reflection is also being mindful that we are part of this system that hasn't always done the best for folks, and knowing that we might have to offer some acknowledgement of that for our patients to want to open up to us. So there's these biases we have that might not necessarily show up as clearly in the medical setting, but our patients might try to let us know. We should be open to hearing that. And just to give a specific example of that, as a dietitian, I see a lot of patients coming in with concern about weight bias, fat shaming, and discrimination based on body size. And I'm even thinking of this case study here, and elevated BMI, obesity is the diagnosis, but we're dealing with someone who's having trouble eating, financial insecurity, and I could imagine getting a referral as a dietitian to help that patient lose weight. So that's something that's coming up a lot, especially in the medical setting. And we know that weight discrimination can have a serious damaging impact on our clients, whether it's doctor shopping, not coming back for follow-up visits, skipping medication doses, binge eating, and weight cycling, and how that leads to worsening diabetes and heart disease. So checking our own biases, I think also could mean, making space for our patients' biases and acknowledging our role in that.
Thank you. These are all really important comments. Does anyone else have any questions or comments for the panelists? Give people a moment. While we're waiting for some other potential questions or comments, I wonder if any of you can, related to the specific case, give us some examples of how we might acknowledge some of our own biases in our own fields and how we might address that with this person and the family that is presented here. I think concrete examples are often, especially with language and how we might speak to someone, are often helpful. Any of our panelists can answer.
We're thinking.
One of the things that comes to mind certainly is when we see folks that are having a hard time financially, oftentimes that comes with assumptions around what they are or are not able to do, as well as their level of education and their ability to understand. So we always have to be really mindful of, anyone can fall into those financial hardships. It doesn't mean anything about your health literacy, doesn't mean anything about your education, doesn't mean anything about your capacity, any of those pieces, right? But that we need to do a whole assessment to be able to meet folks where they are. And when folks are in financial distress, to the points made earlier, their priorities may not be the same that the priorities we think they are. And we oftentimes, again, I can't help but bring up the structural issues, right? How many times do we have a food program where you have an entire family living in poverty, and you have a food program that is helping the one person that is a part of that family? So for any of the folks that are parents in that room, can you imagine being told, like, your one kid gets to have this access to nutrition, but only that kid, and not all the other family members, not the other kids, not the grandparents, not the brothers, sisters, aunts, uncles that are living in that house? Do we really think that's going to be a successful intervention? Or, like any rational parent, is that person going to take the additional resources and share it amongst the folks that are living in that home? So again, thinking if we are not getting the outcomes that we think we should be getting with our interventions, not patient blaming, but asking ourselves, hey, what are the underlying structures or assumptions we might be missing here that are really going to change the outcomes for this individual?
When you mention financial, also, we talk about you can think about the cost of prescription costs. And we think, and I hate that term non-compliant. I really don't like that term because we don't understand what's going on behind the scenes. Why is that person not taking that medication? Maybe they're not taking it because they can't get it. Maybe the pharmacy, which we've had problems before, is not stocked with it. And then the next one, they have to travel to try to get the medication. And then you have to have access to the ability to travel to get it. That's going to cost you money to try to do that. It's all connected. And sometimes we don't really put those dots together to realize, even though it looks like something small, it may look like something small to us, but there's a lot of things that's behind that will make it even more of an issue for the person that's going through it. So I hate that term non-compliant.
One of the things that I could speak to in the case certainly is if you look at the speech language pathology part relative to swallowing, it's a quick fix. So here's some strategies that need to be put into place, and the patient needs some reminders. And lots of times we see patients that are, quote, non-compliant with their strategies. And if they would just do these strategies, the aspiration risk would be gone and we'd be, happy as can be. But I think this is a perfect case to almost step back and observe what's the process. So this is a multi-generational family living in one house, right? Mealtime is likely maybe busy. There are multiple people sitting around the table. If there's a table, we don't know again what the financial stability is, given that the husband has recently lost his job. Culturally, what does having the child or the grandchild give directives to the grandmother mean to that culture and that family, right? That is sometimes not acceptable, not well supported. So the simple idea of here's some compensatory strategies, we just have to remind the client to slow down and make sure she's sitting at 90 degrees and take single bites is really easy for us until we think about all the aspects of care and all the aspects of that family's life. So I think as practitioners, and this might sound like perfect world scenario, but as practitioners, we have to look at not only what the patient is saying is reasonable, but what's the scenario? I mean, I think we're starting to do it better in the birth to 3 arena, where we go in the house and we step back and we look at what's happening and then we infuse ourselves. But the same thing would need to happen here. So I could easily say, oh, to the daughter, well, you or your granddaughter, you or your daughter could just remind your mom. In lots of cultures, that's not acceptable. It's not appropriate. So what I've done is almost rattle the family unit even more, and that's not supportive. So I think that's just, one other consideration to make. Sometimes recommendations don't work. So we have to step back and think not only about the patient, but the environment in terms of noise, in terms of supports. It's a lot of extra pressure to put on the daughter. Is she the only one that's, is she working? Who's home? And then there's the risks that come with that. So just another example.
I think another consideration that you might want to look at is the number of medications that this patient is taking and whether there are copays, because I've heard a lot of patients complain, it's $5 for the copay, but when you're taking this many medications, that's a lot of money. And it's copays for every time you go to the doctor's visit. So if you go to different specialists, that's another copay. So they stop going or they start cutting things out. And then there's transportation costs. So a lot of these things that seem very reasonable, that, who can't pay $5 for a copay? A lot of people can't pay $5 times 7 medications, times transportation, times all of those things.
Thank you. As we, oh, someone else want to comment?
No, I put out the problem, but I never put out a solution. So what is the solution? You know, advocating for increases in coverage, that Medicaid coverage, whatever the coverage is, even that $5 may just be too much. So I don't know what the solutions are, but we never go wrong with advocating for our patients.
And then certainly thinking about how can we structure appointments instead of having 3 different appointments on 3 different days? Can we have them on one day? Can we decrease that transportation? Can we decrease the amount of time we're asking someone to be out of work to either accompany their loved one or to come to our appointments? So what does it really mean as a healthcare system to be patient-centered? For us to be able to have a high yield impact experience for the patient and not just continue to center the way that we schedule and show up based on what our needs are as the care team.
And just speaking to this shift towards value-based care, you know, I am hoping down the road we might have more flexibility to waive the physician's copay, knowing that overall the reimbursement might be better if the patient is making it to those key appointments. So, you know, reimbursements make such a big difference here, and we might have more wiggle room in the doctor's office than at the pharmacist.
Very good points. And we have a couple of good points in the chat also about using language, being mindful of key terms and phrases that the system has normalized and has put forward that perpetuate systemic racism. And also true that patients don't often know how to read their explanation of benefits. They don't know how to ask questions about them. The jargon is overwhelming. So it's that's another problem that we need to take on, I guess, as a community, and trying to help people understand what their insurances cover, period. In these last moments, I wonder if we might all start considering some action steps that we could take to move forward. How might we connect to other members of our teams, other interdisciplinary members of our teams? How might we start to advocate for our patients to do better in terms of addressing social determinants of health? So if anyone wants to suggest some ideas for next steps, either in the chat or unmuting yourselves, I think that would be a nice way to finish our evening together.
One of the things that I was thinking that we could do is get involved in healthcare policy making. You know, I know for a fact that many nurses complain about things, complain this is wrong and that's wrong. But what are we doing about those issues? I've done it. You can write to your congressman, you can write to your mayor, you can write to whoever. You write and they will respond. But if enough of us start doing that and get on boards of these health policy makers. There's a lot of things out there. You can join the community, what do you call it? The community, oh God, it just went out of my head. Oh God. Your councils, there's precinct councils that you can go, they talk about health and how you can improve your health. The city council, that's what I was trying to say. City council, get involved. Go when my neighborhood district, they send out a lot of information about meetings and things that they're talking about healthcare and talking about what's going on in the community. Go out there, get involved, ask questions, take some information with you so that you can improve them. I'm also talking about some of our nurses who say, and I have said it too, the community doesn't know what we do. And for them to know what we do, we have to educate them, tell them what we do, get out there, be seen, be heard. It's just something that I've been thinking about for a while. And I'm starting to advocate for that more.
Yeah, I'm totally with that, getting out of the clinic and into the community. And that's also a great way to build partnerships. And a lot of the resources that we don't have in the medical room, are available in the community. And there's grants that are going to these programs where they might need people that we have the ability to refer. So, we have these case-by-case situations where we have this breakthrough moment with a client and we're helping them. And that's just maybe that foundation we need to really build a community connection, a community partnership, and see where that can go. And some of that really just starts even with participating in a community health fair and seeing, 50 other tables there with all of the resources that are available in your district or in your zip code. So as often as possible, getting out of the office is really helpful.
And I couldn't agree more about using collective voice and our collective power. We do not understand how incredibly that can move the needle. And when we are in those places to do that work, the first question is always who's at the table and who's not at the table, right? We carry a relative privilege, although it may be varied amongst folks who are here based on our positionality, based on our access to education, based on where we are within our institutions. And it is our responsibility to use that privilege to first ask that question about who's at the table and who's not at the table when we're making decisions at the level of our clinics, at the level of our institutions, and at the level of policies if we are working to be in those spaces and advocate in those spaces. So really being clear that if we have our patient and community voices and we are helping to lift up those community voices around what the real needs are, what the real priorities are, and I agree with a lot of our earlier comments that must mean that we universally assess social determinants of health in a structured format that allows us to communicate that information across our own internal care teams, as well as externally with our community-based partners, with our policymakers, to show them the real needs. And then meet those needs with closed loop referral systems, not throwing papers at a patient and telling them, here are all these resources, good luck. That is not closed loop. That is not meeting our patients where they are, but really being able to close the loop, track if we're closing it, and then do our own PDSAs of, hey, we thought that was going to be successful and it wasn't. Let's dig deeper here. Let's actually go into the spaces, into our communities, in the front lines, and understand where are the gaps and what is it going to take, listening to our community to be able to close those.
Thank you. And we have a suggestion in the chat about going to our community boards, which I think is also really important. And I think the idea of going outside of our offices and outside of our own little boxes is really important too. Does anybody else have any comments or questions about our next steps or ideas for moving forward? I want to remind everyone to click on the link that is associated with your discipline. The social workers and the dietitians can click on the same link. The speech and language pathologists can click on the SLP evaluation form. There are 2 different links there. We will also send these out via email tomorrow so that if you don't have a chance to grab them in the chat here today, you will be able to get it tomorrow. We do not have a specific form for nursing. You can fill out the same one for social work and dietitians, and we'll find out what the process is for getting the CEU credits. We had some trouble making the CEUs happen for the residents and the medical professionals quickly enough. So we don't have those, but we might be able to do it for the nursing. So you can fill out the form in the event that we are able to get that together. Thank you, Sophia, for sharing your contact information.
I was going to say that too. Thank you, Sophia, because this has been a remarkable conversation. I really would love to continue it at some point.
Collective voice, that's what we need.
Yeah, for sure. And thank you everyone for being here and for being a part of the conversation and for connecting with us. We appreciate that. I think as we connect more in teams, we will be able to do more than just by ourselves and also just within our individual disciplines. So this is a good beginning. So I hope everyone has a great night, and we will be in touch with you with the links just in case you missed them tonight. Good night.
Good night. Hi, good question. I put in the chat that the social work one has a date from 2021. Is that okay?
Oh, it shouldn't. Yeah, don't worry about that. It's a new form. It's brand new, so it should be fine. That might, I don't know where that came from. It should be okay.
All right, no problem.
I
Thanks
thought
so
it
much.
said 2023.
Have a good night, everyone.
I see there's a mistake there. It's okay. We'll fix that.
Yeah.
Sorry about that.
Thank you. This was really interesting and informative and totally relevant. I appreciate it.
Thank you for coming.
Thanks again. Okay. Have a good evening.
You too. Good night.
Okay, so I'm going to sign off now.
All right.
Okay, bye.
Good night.
Say
Bye.
thanks for welcoming us to join.
Yes.
Yeah,
that's
of course.
great.
Thanks
Thank
for
you,
being
Sharon.
here.
Thank you, Gwen.
Thank you.
Thanks,
It
guys.
was-
Thank
it was
you,
a pleasure.
guys.
Bye-bye.
Bye.
Bye.
Bye, Professor.
Bye, Esther. Thanks for coming.
Bye, Esther.
Bye.
I don't know if these folks are waiting or they're just kind of stuck in Zoom land.
I know. We can, should we stop the recording?
Oh, yes. Good.